I just want to point out that if you're having any technical difficulties, please call 1-866-299-3239 for any technical support. Again, that's 1-866-299-3239 for technical support, and we're going to get started shortly with the main webinar. Thank you. Part of the CARE webinar sprint on payer mix and operational efficiencies. The webinar is being recorded today and will be posted on our website on ctacny.com along with the slides. Throughout this webinar, if you're having any technical issues, please chat those to Evelyn Kleinbart on your right-hand side in the panel. And if you have any content questions, please chat them to me. Currently, I'm under the name of Chris Copeland, so you can access any questions you have that way. So I'm going to let, I think, Chris to kind of kick off the webinar today and get us started.
Okay. So good morning, everybody. It's great to be here. I'm pleased to be doing this. And we have 4 agencies who are on the line who are part of this webinar. We have Beaker Shalom from upstate, Catholic Charities from downstate, Community Concern of Western New York from upstate, and EPIC from Long Island downstate. And there may be other agencies on the line, and welcome to all of you who are here and listening. So the agenda for today is after we've done introductions, to do an overview of the payer mix and operational efficiencies. And then really we've divided this into payer mix and operational efficiencies as 2 parts of the webinar, and really trying to do some deeper dives into both of those. Next. And really, the context for today's for this today and the goals are that we're really setting the context for today's payer mix versus payer mix of tomorrow. We all know we're in a huge transitional period, and really to get our be prepared for what's happening with managed care, understanding where we're at, but understanding what we need to know for the future is incredibly important. We're going to be discussing strategies for addressing your payer mix, and you can see some of the areas we're going to be talking about there: service system diversity, workforce skills, third-party billing, and marketing. Marketing to maybe other underserved populations than you're working with at the moment. And the key focus is really on expanding the number of people we serve. And this is critical, I think, in terms of managed care coming through, is providing value-based and not just necessarily volume-based services. And that really is a big difference between where we are now and where we're going within managed care, and we'll be talking about that at some length. This is a webinar which provides some of the background information for the strategic calls that you'll be having later on. The problem-solving calls are really intended to be where you brainstorm detailed solutions to issues in your clinics, and not really what we'll be covering today. I've already said who's on the line, and welcome again. I got my slides mixed up here. We're a small group. Given the mix between upstate and downstate, we weren't able to get together as a group during the face-to-faces. So the first meeting, the first call with Jim Montfort, who's going to be your facilitator. He's a senior consultant and manager at financial services at CCSI, which is an upstate provider. We'll spend a bit of time getting to know everybody on the call, and really want to emphasize that the way we've scheduled and organized these webinars and calls is that it's your ideas and a collective brain trust are going to help you solve problems within the clinics and prepare for managed care. Jim will serve as an expert resource and be able to identify other ways that CTAC may be able to help you. But really, this is about you putting your brains together and working collectively to come up with ideas. And if there's one thing that came out of the face-to-face meeting on a week ago downstate, was that the ability to talk and bounce ideas off each other was seen as incredibly useful. Just to recap the face-to-face meetings, and I believe the upstate clinics couldn't make the upstate one. Just to recap how we're going to be working in those phone calls. We're using a problem-solving technique that comes out of the business world that's been adapted for treatment approaches, most notably, I think, from my understanding with multifamily psychoeducation, is that problems presented by clinics or a clinic would have all of the participating brainstorming solutions coming up with ideas that the clinics would then, the clinic presenting the problem would prioritize which of those to take away and implement. And that feedback would come back to the following phone calls. So it's a way of getting thinking into your clinics that you might not do if you were looking at your own problems. It's sometimes seeing the wood for the trees, I've found over many years, in terms of looking at problems within our own clinics, and other people seeing that, seeing the problems and offering solutions can really free up some of the log jams we have. So that's the model we're going to be using, and I think it'll become fairly apparent. It's a fairly straightforward model as you go through those phone calls. You'll be reporting on the process indicator for this for this group, and it's really about collections by payer mix. So we'll be looking at for feedback from your clinics as to you knowing how much of your revenue by a percentage is from different payer sources, so you understand what the collective payer mix would be. One of the other things we used in the face-to-face meeting was issues being shared by clinics and then redefined by other clinics, reframing based on a new perspective. So again, it's another technique that we used. Is so I would state a problem within my clinic, and it would be reframed by other members on the call in 3 different ways. Again, it's another one of those problem-solving techniques to free up innovative ideas within your clinics, and we'll be using that technique as we go forward on the calls. So, quick chat question. I think you can see on your screen. Is there anything missing from the above goals? Anything you would like to discuss in this webinar, or post a question? Please use the chat boxes. This is where we can get as interactive as we can be on a webinar. So please, if there's anything missing or you have questions as we go along, we'll be monitoring those chat boxes and we'll answer them as best we can as we go through. Please can you answer these questions? So the polling question number 1 is your entire core team in attendance for this seminar? A, yes, B, no, if you could answer that. How many people in the room are viewing this webinar? This gives us an idea about the numbers of people using these webinars. It's very important for our feedback to the state and understanding how well we're doing. And who's on the line? Finance, clinic leadership, executive leadership, clinicians and professional staff. So this is helpful for us, but also for yourself to reflect on whether you have the right people in the room, the right people listening to this information, therefore the right people on your team to tackle these issues. This is a sort of central theme that we've been working on all year, is making sure that you have the right team together. So just give a second for those polling questions to come in, if you would.
Okay, Ev, I think we're probably ready to shut it down. And the polling results should be coming up shortly.
Okay, so mostly we're all set with the 55% are okay with the, 55% don't have your core team there. So you're only 10% of you do, so that's clearly something to work on. And that's reflected by the fact that many of you are listening to this on your own. The vast majority are listening to this webinar on your own. And the missing people in this seem to be clinicians. That's interesting in terms of, it makes sense, but I hope you can work with your clinical staff to make sure they have an understanding and buy-in outside of these webinars, a critical point. So thanks for that. So now I'd like to turn over the webinar to Peter Campanelli. I think a lot of you may already know Peter. He's recently joined the McSilver Institute after around 26 years of being the founding president and CEO of ICL, and I think if there's anybody in the state knows how to make things work in the changing times, Peter's one of them, and will give us a lot of insight. Peter's going to lead us through this webinar, and I'll be joining in as and when I can on the different slides. So Peter, welcome, and take it away.
Thank you, Chris. That was really very good. So we're going to be going through the next 20 or so slides, and there'll be several questions that will come up from time to time. We'll go through the questions in a way very similar to what you just experienced. We'll put them up there. We'll indicate that there are chat questions or polling questions, and we'll ask you to respond, and we'll give you some time to do that, and then we'll try to respond to what you put up on the screen. If at any time you have a question, feel free to use the chat box, and we'll try to respond to your questions. We've got people monitoring those chat boxes to make sure that we don't miss anything. So we're going to talk a little bit about payer mix and operational efficiencies. And I guess the first thing we want to talk about a little is what payer mix really means. Payer mix basically denotes the different people who pay for the services that you provide. They pay under different contracts, they pay under different billing systems, and ultimately when you put all of the payers together, you get something called a blended rate, and that's pretty much the rate that represents your revenue structure on an ongoing basis. Right now, downstate, the APG rate is something like $155 a session, but that's generally not a clinic's blended rate because there are other payers that probably pay less than that. That happens to be the gold standard. So it's important for you to know what your mix is, and to understand that the payer mix is going to be changing. As Chris pointed out in this entire presentation, we're going to be fluctuating between the here and now and what we expect to be happening after 2016 or 2017 once managed care is fully entrenched. We've been told that the APG rate will stay in place for at least 2 years after managed care sweeps in. And so we're assuming somewhere around 2017, but 2017 is just not so far away. So a lot of the things that we're going to be talking about will be addressing the situation as it'll exist post-2017. Operational efficiencies, on the other hand, don't have to do with revenue except for the fact that they basically will help you generate more revenue. And those really relate to the types of services that you're offering. What's the service mix? And those are going to change substantially, as we'll talk about a little later on after 2017. The availability of services through direct provision or partnerships or affiliations. One of the biggest things that managed care companies are looking for is the ability of providers to provide a wide range of services, whether they do it directly or whether they do it through linkages or partnerships is not of a lot of concern to the managed care company, but they definitely want that kind of comprehensive service system available to their members. We're going to be talking a little bit about how these services may get reimbursed in the future. Different types of services, different ways of being paid for them. And we're going to talk a little bit about information on services that you can distribute to communities and how do you market your clinic and these new kinds of services to communities out there. A successful management of payer mix depends upon optimizing your operational efficiencies. There's no question the two are connected. A world post-2016. Again, let me remind you, the chat box is there. If you have any questions, please feel free to use it. The transition to managed care organizations. Well, we all know that managed care is going to take the reins of behavioral health care in a way it has not in the past. And we've got 2 years from that point to work within an APG Medicaid system and then at some point that APG system will probably go away and be replaced by something. Some of the things that we're hearing, and not only from managed care companies in this state, but managed care companies across the country, is that they're very much interested in paying for value-based services versus volume-based services. A fee-for-service system is fundamentally a volume-based system. You basically are paid a fee when the client walks in the door, sits down, and begins interacting with the therapist. And most of the time, no one is really paying a lot of attention to whether or not there are measurable changes in behavior as a result of that interaction. The managed care world is going to start focusing on value-based services and expecting to see demonstrable changes in behavior as a result of therapeutic services that are offered to clients. They could do that in bundled payments, such as episodes of care. They could do that based on benchmarks, which we'll talk a little bit about. But essentially, payer and service mix are going to be completely different. So the key question to consider is, how do you optimize the current state, the state you're in right now, while also preparing for the future? I'm wondering if anybody out there has had any discussions at all about what their systems need to look like in the future when managed care assumes control of billing systems that and payer systems that are going to be out there. Let's take a second, and I'll just wait and see if anything pops up on the chat box.
So there's nothing coming up, Peter, and I'd suggest that as we're listening to this, something coming up? Okay.
I actually have one.
Okay,
all right.
There we go. The model number of visits in an episode of care at a New York State clinic
is one.
That will not change without deregulation. Okay, so let me see if I understand what you're saying. The model number of visits in an episode of care at a New York State clinic is 1, and that will not change without deregulation. You're quite right, and there's no question that the State Office of Mental Health and the State Department of Health are going to have to take a look at that. But when I referred to episode of care, let me basically tell you what I was referring to. Let's suppose you've got a person that has been in care with your clinic for some period of time. And let's suppose that you could tell that that person required 25 sessions a year or 30 sessions a year. The managed care company could very easily say, so for John Doe, who's required 25 sessions of care a year and probably cost $5,000 a year to treat, we're going to give you $4,000 a year to treat him, and you're going to be allowed to regulate that care and decide how many times he needs to come in based upon what he really needs, as opposed to what's been happening over time. So that's basically what an episode of care is. An episode of care, if you're paying by episodes of care, is on an annual basis, how much care does this person need, and how much can we reimburse the clinic for the care that person needs. On the upside, if you can manage the care well, and if you can manage the individual's clinical needs well, you could wind up actually saving money from what you're being paid in an episode of care. On the downside, you may wind up losing money on an episode of care. So that's basically how managed care companies will probably, if they go to episodes of care, will probably define an episode of care.
You do raise an interesting point, Andy, though, that if Jerry, sorry, that if the most common number of visits is 1, I have a different thought about that and how managed care companies will view us if we're not able to engage with clients, because that's going to be an important aspect of an outcomes-driven treatment is that people are engaging and we can prove that they're getting better over time. So it's going to be interesting if all we can say to managed care companies is that people most often only come once. They're going to have some serious questions about that as we go forward, I think. Interesting point, though.
That's absolutely true, and it kind of raises a question we'll consider in a couple of slides, and that is, how do you measure change?
Mm-hmm.
How do you measure outcome? And we'll talk about that very shortly. So if we go on to the next slide, these are the payers right now of service. You've got people who are being paid by Medicaid, people whose care is being paid by Medicare. You've got some people who are in managed care organizations already. You may have commercial insurance being seen in your clinics. You may have an indigent care pool, and you'll have self-pay, although not technically a third-party payer. And you may have individual contracts with foster care agencies and the like to provide services to their clients. Ultimately, you blend all of those together and you get an average rate, and that's the average rate that you cannot exceed in your expense structure if you're going to be financially viable in the future. Now, many of these will be changing, some of them will not. In the managed care world post-2017, there will still be commercial insurance out there. And all of you need to take a look at your commercial contracts and determine whether or not you want to continue providing service to commercial clients or whether you can afford to continue providing service to commercial clients. Commercial contracts generally pay considerably less than the Medicaid rate or the APG rate, if you will, and so they've been problematic. But then there are clinics and boards of directors who insist that those clinics continue to serve the community who have commercial insurance because that's what's needed. So it's an issue that's an individual clinic issue that will have to get resolved as you move forward. The same is true for the indigent care pool and the self-pays. Most often, people who are paying under self-pay regulations are not paying anywhere near the Medicaid or APG rate. And again, there's a limited number of those individuals that a clinic can really afford to see. There's an interesting twist with Medicare and dual eligibles that we'll talk about a little as we move along. Does anybody have any questions about the current payer mix that exists out there now? Okay. We should probably go on to the next slide. We're not going to talk about centralized scheduling during this WebEx, mostly because it's going to be considered under productivity at a later date. But we are going to talk about operational efficiency. And, you know, as we prepared for this presentation, we internally debated on how one would define operational efficiency. And the definition we came up with was to provide exceptional service that efficiently addresses the problems presented by people while providing the highest quality care at the lowest cost per unit of service possible. Now that may sound complicated. If we can just go back to that slide for a second. It may sound somewhat complicated, but it encompasses the three-part aims of healthcare reform: improving quality, having service available to a large number of people, and at the lowest possible cost. And that's where all of healthcare is moving. Okay, we can go on. So the shifting dimensions of both are interesting. When you look at payer mix has multiple dimensions. Where addressing payer mix may be different depending on the nature of the core issues to each clinic. As we said earlier, we're looking at payer mix with respect to whether or not you treat commercial clients, whether or not you're going to continue treating commercial clients, how many commercial clients can you continue to treat, is there a possibility that you can renegotiate those or other contracts that are not paying you what you need to earn in order to be able to keep the clinic viable, and especially understanding what the penetration rate is of all of these payers. The penetration rate is simply the rate at which these payers are represented within your payer mix. So, for example, you could have a penetration rate of 29 or 30% in terms of commercial payers. The APG rate could have a penetration rate of 60%. You would hope. That would be an ideal situation, depending on what your commercial insurance is paying you. But the penetration rate gets to be very important. You should know those numbers as you move forward. Likewise, operational efficiency is dependent upon knowing what the person seeking help needs and how to best provide it. So let me answer Jerry's question before he asks. There's no question that the state will have to begin looking at what services are provided in clinics and adjusting those services to better meet the needs of the people coming in the front door. I'm sorry, Chris, you wanted to say something?
No, I'm fine. Okay.
So the service mix has been changing depending upon treatment science and regulatory reform. We all know that. We all know that there is such a thing as evidence-based treatment out there. We also know now, though, that collaborative care works better with people who have chronic conditions, especially chronic comorbid conditions. And so there's a whole different service system that's going to evolve that will be better for the client, but we're going to have to figure out payment schemes and regulatory schemes for them as we move forward. Next slide. Okay, let's take a minute to catch our breath and to answer a couple of polling questions. So one thing we're wondering about, that first question on the slide, or the fourth question in order, have you ever heard or been exposed to a change effort regarding payer mix or operational efficiency in your clinic or agency? Is this something that you're talking about? Yes, no, unsure, never heard of it? Please let us know. The second question, in your opinion, did that conversation, if it occurred, result in improved revenue or improved client outcome? Yes, no, unsure of the results, obviously not applicable if you never had the conversation. We'll take a minute and let you answer those questions. Take your time, talk among yourselves. Okay, good. So I'm looking at 45% have heard or have had conversations regarding a change effort, payer mix, or operational efficiency. 38% have not. Or didn't give us an answer, actually, and only 14% categorically said no. So that's good. So some of you are talking about this in your clinics, and it's important to keep talking about it. It's important to keep focused on it because the future is coming. In your opinion, did it result in improved revenue or client outcome? Yes, fewer people said yes, 17%. No, 7%. No answer, 45%. And unsure of the results, 21%. And not applicable, 10%. Okay. You know, the 17% who said yes, that's great. The 7% who said no, I think we're going to talk a little bit about some ideas that might be of help to you. And the rest of you who said that you were unsure of the results, not applicable, or no answer, which is the larger group, generally when people don't answer these questions, it's because you haven't. So we'll be talking a little bit about how to get into these discussions. And Jim, as he gets into the facilitated phone calls, will also be talking to you about how to get into these discussions and how to lead change within your organization. So let's talk about your clinic for a few minutes. When one considers various payers in your clinic, what does operation efficiency look like? Use the chat box to your right to send us your thoughts, any thoughts, on whether or not you think you're operating efficiently and what that looks like with respect to the people who are frequenting your clinic. We'll wait a minute and see what pops up. Indeed. Okay. So Jerry, I'm looking at one word, indeed.
I think that was Jerry responding to my comment about the need to do something about the fact that people only turn up once to clinics. Peter, he was saying,
okay.
Indeed.
So, do you have something?
I have something. I just sent it all.
Okay, I've picked up something from Dr. Rodney Demota. Low commercial and self-pay. From Jennifer Colbert, not sure what you're looking for as an answer. Looking for whatever your thoughts are as an answer. But let's talk a little bit about low commercial and self-pay. I assume that what you mean there is low commercial rates and very low self-pay rates. And if you're talking about that, that's a good thing, because obviously it's something that you're going to have to deal with in the future. From Andrew Kuntz, the first step is to get accurate information about payer mix. In the first place, no retrospective but real. Not retrospective but real.
Real time, yeah.
Absolutely true. You need to know what the payer mix is, and you need to know what their rates are. So let me just ask one more question before we move on to the next slide. Are the general payer mix and rates available to all of you on the call? Do you know how to get them if you don't have them available to you? Okay, well, think about that, because we might come back to that question.
And Peter, can I just ask? I mean, I think if the answer to that is not sure or don't know, the calls that you're going to be having, that will be one of the vital questions to ask each other as to how do you get that? Because as Andrew's pointing out, if you don't have real-time information, it's the same with productivity. If you're not able to track people's productivity in real time, what I mean by real time is at least on a weekly basis, these clinics are very difficult to change mid-course. So that will be one of the questions to pose to your colleagues as to how do you get that. And you know, it's a real need in clinics to have finance involved and measuring that. And it may be that you need to take shortcut versions if you can't get it directly out of your billing information, but you need to have a tick and tally on the side about how many people you saw with commercial this week, so you know what's going on a weekly basis. That's the sort of thing to discuss and figure out.
Absolutely right. And actually, I think the next slide begins to take us there, Chris. So if we can go to the next slide. There was one comment that we should include. This clinic tops the state in every variable but payer mix. I'm just looking for new ideas to increase Medicaid and Medicaid managed care clients. 40% of the clients are managed care or Medicaid. I guess that's an abbreviation for Medicaid. Well, hopefully we'll give you some ideas about how to do that as we move forward. So the next slide is around pay arrangements now. We talked a lot about blended rates. We'll put up the next slide. There we go. We talked a lot about blended rates. There is an issue for dual eligibles. I'm sure all of you know what a dual eligible is. It's somebody who's covered by Medicare and Medicaid. And in a clinic, what that means is you have to bill Medicare first. And then you generally get paid 85% of the Medicare rate. And then the other 15% you can bill to Medicaid, which means that you're collecting considerably less than the APG rate on the dual eligibles that exist out there. There's also a lot of issues concerning confusion between what they are receiving and what they're not receiving, and whether or not they're receiving adequate care. You need to know what the CPT is based on services delivered, what's the rate, and what's the weighted rate based on the services that you're delivering. And you need to understand differential payments for Medicaid, Medicare versus commercial insurance. Because commercial insurance is out there in the mix, as we've talked about, and very often those contracts are $55, $60 a session, and the actual cost of care, as we all know, is considerably higher than that. And right now, the APG rate is currently the gold standard. Okay, moving along, key challenges. Today's key challenges: increasing census, or to respond to the person who wrote the comments above, I think it was Jerry, that he needs to increase his Medicaid and managed care volume within his clinic. You definitely need to increase the census, especially among those people who currently receive the APG rate. You also need to increase volume of services. How many people are you seeing and how often are you seeing them? There's two strategies here. One strategy is that you're seeing people on a volume basis right now. The other strategy is that moving forward in the future, you're going to be converting your services so as to be providing value-driven as opposed to volume-driven services. And so you have to be kind of working in both worlds as we move forward. You have to optimize the service mix and provide sufficient diversity of services to meet the need. There are things you could be doing right now. For example, you could be running groups that focus on chronic comorbid conditions and how they interfere with psychiatric treatment, particularly relevant in diabetes, particularly relevant in asthma and COPD, especially if clients smoke. And the more of those groups you begin to launch, the more important the services you provide will be, because those kinds of services will help keep people out of the hospital. And you could run those groups as long as you put in the person's treatment plan that they have these disorders that are driven by psychiatric symptoms, and therefore you're working on getting them to stop smoking, you're working on getting them proper nutrition if they're diabetics. Again, focusing on the interplay between their psychiatric condition and the medical comorbidity. And these are things that you could be doing right now. There's loads of literature out there on running those kinds of groups. And so you ought to give some thought to actually doing that. Managed care companies are going to be looking for people who can run those kinds of groups. There's also an opportunity that many of you, I'm sure, know about to have your clinic licensed to provide medical monitoring and medical assessment under Article 31 regs. It's an optional service. You have to outfit a room. You have to basically have an affiliation out there with a local hospital. But you can do medical monitoring and medical assessment as long as you have the proper facility and you have some sort of an arrangement with a local FQHC or hospital. In fact, some of those arrangements could also include buying physician services and bringing physician services in so that you can identify people who have medical conditions and be able to monitor them. And that's right now.
Peter,
Yep.
So, Peter, can I just add that clearly the managed care companies and the Medicaid redesign understand that the real cost of healthcare for people with psychiatric conditions is not the cost of their psychiatric care, but the cost of their comorbid healthcare. So if we're talking about increasing census, increasing the number of people increasing the amount of work we're doing with people with Medicaid and Medicaid managed care, as this moves into managed care, those companies are going to be looking for clinics that can have open access, but are providing services for people's whole care, because that's where they see the savings. So that's just emphasizing what Peter's talking about, looking to the future, having more than just our normal or our current mission of providing outpatient therapy to people who have psychiatric conditions is key, I think, to being able to increase our footprint and increase our census in the future.
Exactly right, Chris. And we're going to talk a little bit about collaborative care in the next several slides, and we're going to talk a little bit about creating virtual multidisciplinary teams so that there's shared decision making around people with complex disorders that include serious mental illness and a comorbid medical condition. Managed care companies are going to look for that. They're going to look for providers who can provide that, and those are the preferred providers they're going to want to contract with. And then finally, negotiating third-party contracts. You know, I've been in a position where I've had to negotiate these things, and they're not easy to negotiate. They are lengthy, and very often you need a healthcare attorney at your side trying to interpret many of these contracts. But it doesn't really help not to engage in a lively dialogue with the commercial insurance carriers around these kinds of things. Some things you should know. Commercial carriers have to have adequate networks out there. And because without publicly funded clinics, they're going to be hard-pressed to demonstrate adequacy of network. They really do need you to pick up their contracts. And so it's not something where you basically need them more than you need them more than they need you. It's just the reverse. They need you a lot more than you need them. Not to mention that if you do the math, you basically can't afford to operate loss leader contracts for very long and still remain viable. You just have to do the math. Find out what your expense structure is, figure out what your unit revenue base needs to be, and you'll understand that you can't afford many loss leaders, especially in the coming world. So negotiate these contracts hard, and if you don't have the skills to do that, and many of us don't, then find someone who can help you with it. But don't wait till the last minute and then just automatically renew what they hand you. Next slide. Payer arrangements in the future. Okay, we started to talk a little bit about this a little bit ago. So we all know fee-for-service is not going to exist in the future, so it's not even up there. Fee-for-service across the country is a payment methodology which is rapidly disappearing. There are other possibilities out there. Certainly individual capitation is a possibility. Individual capitation is unlikely in Article 31 clinics, because, quite honestly, you don't have the kinds of reserve structures you need to be able to absorb losses should losses occur within individual capitation. Episodes of care are a little different in the sense that you're not online for the entire capitated rate. You're being given a base rate for selected individuals. That selection could occur on an individual basis. More likely, it'll occur on a diagnostic basis. But they'll tell you this is the amount of money we can pay for this episode of care on an annual basis for this individual. It'll be limited probably to outpatient. It would not include inpatient. So it would not be a full episode of care, but rather an ambulatory episode of care. And that's when tracking individual patient care gets to be really very important. It's also very important not only tracking it, but understanding the ongoing cost of it. You need a very good electronic health record to engage in any of this kind of payment structure. And that's why when managed care companies talk about not wanting to contract with anyone who doesn't have the capacity to meet the technological needs that they have for reporting, that's one of the issues. There could be benchmarking. You know, in some of the physical disorders, there is benchmarking. If you are dealing with an insurance company that is farsighted, that insurance company may say to you, well, there are certain benchmarks we want you to hit in treating depressive episodes of care. And if you hit those benchmarks and people begin to evidence improvement over certain periods of time, we'll not only give you a base rate, but we'll give you a bonus of some sort. And so the benchmarking generally involves hitting certain targets with respect to treatment and then receiving a bonus in addition to some sort of fundamental payment that they'll give you. This is really very important when you think about assessing clients and understanding what these benchmarks are. It's also important about understanding the metrics involved rather, in episodes of care. In order for you to be able to measure improvement, you have to have a clear understanding of where you started. So in assessments, particularly standardized evidence-based assessments, gets to be real important because then you can track improvement over time. And that brings us to the last item, utilization review. When you're treating someone and you're not seeing the kinds of improvements that you basically are expecting to see, is there a clear process that will allow you to engage in a utilization review that helps you understand why you're not making that progress? These are all the things that managed care is going to be looking for. So I'm wondering, and we thought we'd ask you a chat question and just give you a couple of minutes to answer it. In the new world order that's coming, which of these systems would you prefer? If you could just use the chat box. Before I get to the next question, just use the chat box, and if there's a particular item there that you think would be better in terms of working within, let us know.
So while you're answering that question, I'll just add some context. One of the things we understand now is that the managed care companies have a lot of Medicaid data on use of services, and they're beginning to profile our outpatient clinics to understand how long people are receiving services within our clinics against diagnostic criteria, et cetera. They can do a lot of things with that data. I certainly know our clinics here at ICL, 50% of the people in service in treatment have been there over 2 years. I know that's going to be a huge problem when if we're dealing with a utilization review, we've got 12 sessions for 6 months, we've got to ask for more. That's going to be a huge problem for us when we walk into a managed care environment. So a lot of these different payment methods fundamentally rely on us knowing individually how we're doing with clients, but on aggregate how we're doing as well. And if you don't have that data at hand, like I don't, we're going to have to make some big changes over the next year to make sure that we're ready for this different payer arrangements.
Absolutely right, Chris. So I just got a message that we're running a bit behind and we need to speed it up in order to get through all the slides. So we'll try to do that, but we don't want to sacrifice speed for clarity. So if we go on to the next slide, key challenges. Well, we've been talking about this a lot, measuring client outcomes. In order to measure client outcomes, you need to have a good assessment system in place. It has to be a standardized assessment instrument that through repeated measure design, you can just keep repeating the assessment and determining whether or not you're seeing improvements relative to some sort of baseline. You also have to have a sense of the number of sessions or dosages that you're going to be utilizing in order to work with that client and how you provide them. As regulations begin to relax, you know, you may be able to provide them in different dosage levels. You could have half-hour sessions with people. You could basically have conference calls with people when they need to be talked to, but they don't necessarily need to come in. Again, remember that the Medicaid regulations that you've been laboring under all these years are going away. Those Medicaid regulations are not going to exist in a managed care world. And then, of course, as Chris just pointed out, you need to be able to measure the cost of services provided to clients. And if you can't do that, in the long run, you're going to be dead in the water. So you really need to begin thinking a little bit about that. If we go on to the next slide. Well, we'll give you a minute to think about this and ask you to chat to us and tell us what you think would be of sufficient value to managed care companies that they would be willing to pay for it. Take a moment, think about this, discuss it among yourselves. We did have some managed care leaders into NYU recently, and we asked them this question, and we'll share with you what they said, but we'd be interested in your thoughts. Anything?
That's benchmark.
Yeah, I think you're right, Jennifer. I think that they would be willing to pay for evidence of improvement vis-a-vis a benchmarking process. And when we asked them this question, they basically said that they wanted to see evidence of improvement. They wanted to be able to deal with clinics who could measure client outcome. They wanted to be able to work in a value-based as opposed to a volume-based system. And they wanted clinic staff to be sufficiently versed in some of the comorbid medical conditions so as to be at least literate on what some of the conditions are that some of the clients might be presenting to them. And they also stressed partnerships. What kinds of partnerships exist between clinics, hospitals, FQHCs, vocational educational programs. They really want a wide diversity of services available to the providers that they're dealing with so their clients can gain access to them. Next question. Next slide.
Peter, we just had the comment come in from Andy.
Okay.
Andy from Astor. That serving specialty clinics, clients, like young children, very disruptive children, substance abusing, mentally ill.
So Peter, maybe I can just comment on that. I think the point you're making, Andy, is that these are folks who have very high Medicaid costs. These are people who, need the insurance companies are going to be really interested in, because I think certainly substance abuse in mentally ill people I'm sure are using many ER and hospital visits for very little progress around their health and the recovery. So specialty treatment services for those people who you can show good outcomes for are exactly what they're going to be looking for. I mean, I've had the look of sitting down with some managed care companies over the last 6 months, and our conversations from our end started talking about, we do this evidence-based practice, we're really good at this, we're really good at engaging people, and the response from the managed care companies was always, well, so what are the outcomes? So how we get there sounds much less important than the outcomes. So when we ask these questions about what are they willing to pay for, they're willing to pay for good outcomes, i.e. reduce costs, increase health, and they're going to be looking at some of these very difficult specialty clients that cost a lot of money. It's a very good point.
Mm-hmm. Yeah, I think that's absolutely right, Chris. And one of the things that we've talked about with a different client is the whole notion of teaching parents how to better manage their children in their home. Many of these kids often wind up in emergency rooms, and they wind up getting admitted to hospitals. So the more strategic you are in crafting clinical interventions that will help parents and teachers with these children, the more valuable that service will become. Okay, operational efficiencies. So when you think about your clinic, some of this stuff is a no-brainer. Ensuring long-term clinic viability, keep your eye on payment rates, make sure you're serving priority populations. There will be populations that, as Chris pointed out, are at risk for hospitalizations and emergency room events. Those are the populations you really want to make sure you're serving. If you have local shelters, for example, in your community, and you've never talked to the shelter director, and you're not serving any of those shelter people, you need to reach out to them and find out why, and see if there's any way you can form a partnership with them wherein you can provide services to that population. Keep in mind that people who receive correct services generally are going to improve, and people who receive incorrect services or services that are of no benefit will not improve. And also keep in mind, as Chris pointed out, that the managed care companies will have access to a tremendous amount of data. They'll have access to data on who's getting hospitalized, who was treating them before they got hospitalized, and they'll be able to consolidate that data and take a look at, through a profiling system, which clinics are really achieving managed care company objectives. The one interesting thing here is managed care companies are no longer simply interested in making profits. In this new system we're going to, they're responsible for all of the costs, inpatient and outpatient. So it's no longer about cherry picking. It's no longer about simply making sure that you can figure out a way to reduce access. Now it's about keeping people out of hospitals, keeping people out of emergency rooms, and providing them with the service that they need. That's a big shift. Key strategies for viability. We've said all of this in the past, but some of it deserves expansion. Increase the diversity of services, i.e. your service mix. If you don't provide integrated dual disorder treatment for people who have substance abuse disorders, you ought to begin thinking about it. If you don't do standardized assessments for substance use when people walk in your front door, as a public health service, you ought to start thinking about it. If you don't ask questions about trauma, when people walk in the door, and as you take their history, understand what some of the indications of trauma are going to be, you ought to really begin training your staff and start thinking about it. Collaborative care, as you begin registering people who have comorbid medical conditions, keep in mind there are other providers that are dealing with those individuals, and you need to be able to figure out ways in which you can communicate with those other providers so that your care plan and theirs integrate and mesh well. We talked about medical monitoring and medical assessment. Within your own clinic, you can do that. Integrated care, you can do that within a medical monitoring and medical assessment program within your own clinic, or you can just reach out to a local FQHC or to a hospital and work with them. And finally, there is an evidence-based process out there called wellness self-management, where basically you're teaching people how to take much better care of themselves who have serious mental illness. Again, it can be crafted into a group across a number of sessions. The groups can be billed for. It can be done right now as you're moving forward and getting ready for other aspects of managed care. But if you're not familiar with wellness self-management, you should become familiar with it. It's broken out into protocols, so it's all already organized into groups for you. So be sure to take a look at that. So the chat box question is, do you have any of these services? Are you planning to introduce any of them? So let's take a moment and discuss amongst yourselves, and then use the click to raise your hand button to speak, or use the chat box to your right to send us your thoughts. Okay. I guess you should just use the chat box, but please send us your thoughts. Good. Jennifer, we have some, and we're looking into as many as possible to broaden our services. Good. Very good. Jennifer, you know, one of the things that you might want to do is start putting together a menu of all of these cutting-edge services that you're putting together in your clinic, and have that menu available to market in the community and to market to managed care companies. Something I've not seen clinics do, but they should really begin thinking about doing, is essentially having that kind of menu of services out there. Physicians do it all the time. They talk about all the things you can get done in their offices, and having that kind of literature available would be very helpful in a mental health clinic as well. But that's good. That's very good. From Dr. Rodney DeMota, yes, but we need to spend more time developing the implementation strategy. That's right. You're absolutely right. We'll talk a little bit about how to implement this stuff. And Jim Monfort, who's on the call right now, is going to be walking you through implementation strategies. Our slide today is simply to acquaint you with different generic ideas about implementation, but Jim will walk you through that, and we can certainly help you with implementation strategies. It's not easy to engage in organizational change with folks who are in a clinic, with therapists who are in a clinic, but it's essential that you do that now. Another caller said that they are in the process of developing medical assessments. Great. And as you do that, Make sure you work with a partner in the community that can be your medical backup. That partner probably has a lot of standardized forms for medical assessments that can be used. Those forms can be used to train your staff on what to be looking for as indicants of comorbid medical conditions that may exist. So it's really good that you're doing that and you're in the right direction. That's a great idea. One challenge is to get people to attend a wellness group. Absolutely, that's true. And engagement is never easy, and I think we're going to be running a seminar on engagement. But generally speaking, if you, on an individual basis, get people into a room and begin explaining to them why they need to go to wellness, what could happen if they don't go to wellness, and why it's very important for their well-being and for their rehabilitation for them to go to these kinds of groups, and then make all the follow-up phone calls and everything else that you have to do, you can start getting these folks in. It's not easy. Groups have never been a priority, at least not in the clinics that I've been associated with, but they will be and will continue to be in the future. Any other questions? Elizabeth, I'm sorry, Ed, same question?
No, that's it.
Okay, so running very behind. Okay, so we need to speed up. We went from behind to very behind. Let's go to slide number 30, marketing. I'm just going to breeze through this. These are all the affiliations that you can basically create out in the community. Housing providers, you have something they want, they have something you want. You want to be able to refer clients to housing when it's available, and you want them to refer clients who live in their housing to your clinic. Vocational providers, mobile crisis and outreach, chemical dependency for substance abuse disorder, building an in-house capacity for evidence-based integrated treatment, care management via health homes. You don't have an affiliation with health homes, you've got to get one. It's really essential. Lots of referrals are going to come out of health homes. And in-house services or linkages to physical health providers, which we talked about. If you think a little bit about communities, you know, the MCOs are seeking clinics that are have linkages to social support and ancillary treatment. We just did this slide. We go to the next slide?
Yep.
Marketing, prevention, and public health solutions. Okay. Basically, as you market in the community, the MCOs seek clinics that are active referral sources within the community. You need to be doing outreach to PTAs. You need to be doing outreach to community-based assistance centers for families. You need to be able to do outreach to other kinds of churches and other kinds of community groups. If you run a very large system, embedding population-based early identification and prevention tools in your assessment process won't cost you very much, but it will help you a great deal. It will also be viewed positively by local and regional authorities. Things like screening, brief intervention, and referral to treatment measures that could be done very rapidly. And in fact, it's a SAMHSA-approved activity, and SAMHSA is recommending that hospital emergency rooms do it on a regular basis. Could lead to early identification of people who are struggling with substance abuse disorders and early treatment and intervention. Outreach to shelters, we talked about, family assistance centers, online resources to hospitals, to primary care providers. Crafting warm handoff opportunities so that people who are being discharged from the hospital, who may have been seen by your clinic before they went in the hospital, can be picked up rapidly and seen very rapidly within the clinic once they're being discharged, and also working with some of the hospitals and the health homes to prevent ER admissions, because those are the big ticket items that managed care companies are looking at. The next slide, please.
So the basic, I mean, the important point about this is being woven into a web of care that the clinic is an essential part of. I mean, that's the sort of way I think of it in terms of the strategy. So when managed care company talks to a hospital about, so what are you doing about ambulatory outpatient clinic, mental health clinics, they've already made that connection and said, well, we've got a really good working relationship with X clinic. And those discussions are happening now between managed care companies and hospitals and FQHCs and providers. So the more interwoven you are and essential to other providers, and managed care, the managed care and the HARPs are really going to be looking at the whole person, is going to be critical. So this is less than a hypothetical marketing strategy. It really is about how do you become essential to other people, and how do you become top of mind to other providers in the area that you may not have normally been connected to. This is no longer about having an open door and hoping enough people come through the door, because managed care companies are going to control who ends up in your clinics. So you need to be known, and you need to be trusted by other providers. Oh. If you're not doing that already, time's now. Peter? Oops. So Peter got cut off. So in the spirit of keeping going, I'll work through some of Peter's slides. I think that this marketing and providing evidence-based assessment and treatment is essential, because really what we're talking about is outcomes. How best can we get to the outcomes that the managed care companies are going to demand? And those outcomes are reduced ER visits, reduced hospitalization, increased self-reliance on wellness. How do we get there as quickly as possible? And it's not necessarily that the managed care companies are going to care so much about that, but unless we can get improvement as quick as possible and prove it, we're not going to be in a position to be able to say, trust us with the treatment of your treatment of the members within your managed care company, because we can get people to wellness as quickly as possible. Simply, you need to know that, and often evidence-based assessment and treatment is the best way there. And if you're not clear about what the HEDIS and NCQA standards are, I couldn't quote them to you, but they're very much what healthcare looks at in terms of how do we know whether people are getting the appropriate level of care and the appropriate treatment. And that's really, if you look at those, they're going to give you a good idea about what's going to be demanded of us.
That's right, Chris. And the HEDIS standards actually contain benchmarks that are clearly articulated, that tell you where you should be and what you should be targeting for certain disorders. My apologies for losing the call, but I'm back now.
Off you go, Peter.
Business partnerships. So fundamentally, you enter business partnerships because you want to reduce expenses and improve collaboration. Again, these should always be bidirectional in nature. You should improve client flow. You should improve client care with these kinds of partnerships. And there's also always an opportunity to try to reduce expenses as you move forward. So what could you look at? Well, you could look at combining billing and back office operations across certain agencies. If you've got 2 or 3 agencies in a geographic area and you're willing to work together, then possibly you only need 1 billing office or 1 IT office to help all 3 agencies. And you could reduce expenses by bringing together logistically those functions. You can contract out to third-party vendors for billing, IT, and HR functions. And there are some really good billing, IT, and HR corporations out there. And you probably know about some of them. As I said earlier, you can engage in joint ventures based on shared functionality. You can basically form linkages with vocational rehabilitation companies to provide vocational rehabilitation and employment opportunities to your clients. and housing and the like. And finally, you can become a third-party vendor yourself to several other agencies if you're a large enough agency and you have an interest in doing that. Again, the future is going to be about partnerships, and it's going to be very important. Workforce skills required in the future, I mentioned earlier, medical literacy, multidisciplinary decision-making, group and engagement skills, understanding outcome metrics, and technology. Next slide. Medical literacy. Staff will develop a fundamental understanding of how to live a healthy life while living with comorbid chronic physical conditions. We're in the process of taking a look at how we can put together some training in this area, but just to understand predisposing factors like the predisposing factors involved in metabolic syndrome, heart disease, asthma, diabetes, understanding all of those things and just understanding enough about them to make sure that they get the care that they need when they have those issues. And again, wellness self-management. We talked about it earlier. It can't be stressed enough. Next slide. Multidisciplinary decision process. Using the electronic health record to engage in virtual case conferences. You have to have a really good, strong electronic health record so that you can interact with other providers out there and form an integrated service plan. The concept of treatment to target, often not used in behavioral arenas, but often very much used in healthcare, basically talks about the provision of specialty care so that you make sure that your client is getting to where they need to get in their own treatment, and you make sure that they see the specialists that they need whenever they need access to those specialists. Again, depriving people of access to service is just not going to make them better, and I think managed care companies understand that at this point. And finally, developing a clinic treatment plan based on a comprehensive service plan approach, that you're engaging with other providers, you know what the client needs across a whole range of areas, and the comprehensive service plan reflects that. Next slide.
So Peter, can I just, again,
absolutely,
perhaps,
Chris, go ahead.
Perhaps the obvious thing about, or maybe not so obvious thing about this slide is that I don't know how your clinicians feel about their practice within the clinic, but if they're anything like clinicians I've worked with in the past, it can often feel as if they're in their own private practice. And the future we're walking into just doesn't allow for that. Clinicians have to be engaged in working with other professions, working collaboratively, and taking account of other people's treatment plans. And so this is, again, preparing for a change is always helpful ahead of time. So if that's the mindset that clinicians have, or maybe the supervisors have, that we're running our own individual private clinics, that's one thing to work on now.
Okay, so the next slide is on group engagement skills. The staff need to understand how to run groups. They need to understand how to engage clients in that process. And you're going to be hearing a lot more about engagement. In fact, the CTAC folks are looking at how they can provide you with training on engagement skills. Part of it, however, is organizing skill-based common content groups, introducing individuals when they're in the clinics, trying to organize things so that you can introduce them to one another, providing them with some icebreakers and basically getting them interested in whatever the common element of the group is. They have to understand that it's going to help them in terms of their roles and their goals. And they have to understand that it may, in fact, that group process may, in fact, be a sharing of support services to improve the life of the individual that you're serving. So all those things get to be important. And as I said, I think the CTAC folks are working on developing training in this area. Next slide, please. Understanding outcome metrics, something that we rarely do in behavioral health. We definitely need to begin to understand how outcome is defined as improvement in functioning. That is to say, improvement in psychological, emotional, and behavioral functioning. Outcome is a measure. It's a metric. It may be collected over time, and it assesses changes in behavior. So that assessment at the front end gets to be really so important. And again, CTAC is going to be working on creating an Outcomes Institute. You'll hear more about that. These measurements need to be standardized, and generally speaking, outcome is assumed to be a result of intervention, treatment, or service. It's not a very scientific way of thinking about it, but certainly, you know, barring anything else that's going on in the individual's life, it's reasonable to assume that. Next slide, please. Technology. Staff has to be technologically proficient, at least with the electronic health record that you have. Technology will help clinics be flexible. You'll be able to get a lot of outcome data on it. You'll probably be able to get cost data on it. So it gets to be very important. Some of you may not have heard of this, some of you may, but in October of 2014, ICD-9 is being replaced by ICD-10. ICD-10 is a much more elaborate coding system. It basically allows you to code and subcode so that you can identify not only primary illnesses, but also comorbid secondary illnesses. You can also identify what treatment was provided, and you can identify outcome, all within ICD-10. It's a really very expansive system. It's somewhat complicated, much too complicated to go into in any detail here, but there are trainings on ICD-10 for those of you who are involved in either running clinics or billing within clinics. It's something that you really need to understand because it's going to be very much involved in healthcare reform. And again, I understand we're thinking about, on the CTAC side of the house, providing training opportunities in this arena. But it does depend heavily on a pre-existing electronic health record. Next slide, please. Okay, so how do I get this done? Somebody asked that earlier. And so we'll try to give you some tips here. And Jim, I'm sure will go into this in detail. And we've got 3 minutes, so I'm going to go through this very quickly. You have to frame change in the context of organizational need. Basically, you have an organizational need out there. It's inevitable that change needs to happen for survival. You should never attempt more than one change at a time. But prioritize your changes. Once you arrive at consensus on the overall goals from a change team, then you go on to begin implementing that change. There needs to be an outline of the implementation plan. The plan should be shared with other people in the clinic to get buy-in. You need to track the implementation. And finally, don't forget to collect metrics that track progress and outcomes. Next slide. We're down to 2 minutes. Additional considerations, specific implementation, research, pilot, concrete next steps. Those all have to do with implementation, kind of selecting something that you want to engage in and then just doing. So I'm going to stop there because we're almost out of time. There's going to be a series of calls that you're going to be engaging on. Justine, did you want to talk briefly about what to expect on each of these calls?
Yeah, I'm happy to do that. And just while I'm moving through these, and Chris and I are going to present it together, please feel free to chat in any questions you have so we can make sure to address it. So Chris had mentioned this in the beginning, and again, this is going to be true for all the CARE cohorts, but this webinar today is for the payer mix cohort. We are going to set up that first call in approximately about 2 weeks, and you should be looking out for email shortly that helps to arrange that call. And it will be a series of bi-weekly calls that we're expecting to have approximately 5 phone calls. And Jim Monfort from CCSI will be your facilitator. So at that very first call, which again we'll be scheduling shortly, each clinic will be asked to reintroduce themselves again. Paramix only has 4 clinics, so it will be a small group. You'll be explaining why you've chosen to address this. We'll discuss group ground rules and the call schedule going forward, and kind of really recap on this webinar and what you took away from it and what you are planning to work on through CARE as supported by your fellow clinics. And we ask, most specifically to prepare that you are prepared with data. So you know your performance indicator in terms of collections rate by payer mix, and you're clear on what you want to change about these numbers. And for the remaining calls, what to expect, each clinic will be given an opportunity to present the kind of key issues that they specifically are working on and taking advantage of the other clinics on the line to kind of get their ideas and different solutions that they can address. And so we'll be setting the presentation schedule before the first call, and we'll also give you a format to work off of to structure your presentation to your fellow clinics. And we want to stress that since it's a small group, it's really important that everyone is able to attend the call. At least some members of your key team are able to attend each call, and that everyone contribute and participate because, again, you really, as Chris was saying earlier, you really are the brain trust for one another.
And I think one of the takeaways I take from creating this webinar is that by the important message we were trying to get across here is that within 10 or 11 months, we're going to be likely to be in a managed care environment. So I think what you've taken from this is the fact that this 9 or 10 months could be well served in looking towards how do we attract a different payer mix than we've been looking at in the past, which is managed care. And that will be, I think that will be the focus of the 11 months time. If you remained looking at your existing payer mix, I think by the time you sorted that out, you'd be looking to figure out how to deal with managed care. So I think the advantage of this webinar or this learning collaborative group is that you can really spend time looking towards planning for the future.
And so just some last notes on kind of logistics. You'll be invited to a listserv shortly that all members of the cohort can use to communicate with the group. It's what we're going to use to schedule the calls, and it's also going to have a schedule that you can access with all the different call information in advance. And this is what we expect for you to have as your primary resource for all content implementation questions. For content questions a listserv can't answer, Lauren Jensen, who's on the webinar today and who really helped to pull together this webinar, she's at CCSI and she's going to be your resource contact to go to with, anything that, again, the listserv you can't get, your fellow clinics aren't answering and you want to kind of get another perspective on. And she can help you to identify further resources by working with Jim, who again is your facilitator. So next steps, meet with your team to brainstorm what strategies you want to address and what your thoughts were from today. Test out the listserv that we'll be inviting you to shortly and give your call availability. And just a short note on data collection, as we talked about today, your specific indicator is collections rate by payer class. We're going to collect at the midpoint of the calls and at the end of calls, and we're going to collect that via Qualtrics link. So you'll get more information on that on your first call, but just wanted to keep you on the loop to be preparing to collect that if you haven't already. These are other upcoming CARE webinars. We just sent out a reminder email that has a link. So if you were in the part of the Paramix cohort, this is the only one that we required you to attend. We invite you to attend these others because you think it's helpful and can provide you extra information. If you have any questions, global questions, you can always feel free to contact me, and my email is right here. And I don't see any other comments or questions coming in, so Peter and Chris, I'll just leave it to you to do a quick wrap-up, and thank you both for a great presentation today.
Well, I think we've covered it all, but thank you and Lauren for all the effort you put into this. Thank you all for attending. We really do appreciate your attendance. We want to hear feedback from you. And good luck. It's going to be a challenging environment, but we can definitely overcome the barriers that we all face to ensure that people are getting good services out there. Chris?
Couldn't have said it better. Yes, good luck, everybody, and look forward to hearing some of your comments and thoughts and feedback as we go through the next few months. Take care and good luck.
So long, everybody.